It's a pleasure for me to present Monika Bayer, Senior Researcher at the Institute of Sports Medicine in Copenhagen. And his field of work is research focused on loading of musculoskeletal tissues, adaptation of tissue and cells, and loading loading and unloading, and optimal rehabilitation for following a traumatic muscle injury. Please.
That's it. Thank you very much, Luca, for the introduction. Thank you, Mario and the team, for having me here, for inviting me. I'm really enjoying it. My name is Monika. I work at the Institute of Sports Medicine in Copenhagen, and really what the focus of my work is, and I hope I'll take you along that journey a little bit, is the translation between mechanisms in physiology and pathology, all the way down to the cellular level, but we also have the patient. It might be an elite athlete, it might be an amateur athlete, and we work mostly with amateur athletes. The whole journey, and I hope this works. I don't know if I should press something. Oh yeah, no, it is. It's just I need to be a bit patient. Good. The whole journey started around 10 years ago, when we started to look into strain injuries. And why is that? Because we have a clinic and we see a lot of patients that have re-injuries, and you know that strain injuries is the type of sports injury with one of the highest re-injury rates. This tells us what? It tells us that something is not really properly healed, or in some ways, some athletes have a non-healed or not perfectly healed tissue. Anyway. Good. And I don't know if I can use this one. Not really. There should be I'll use my arm and you use your imagination. When I talk about muscle and muscle strain injuries, we need to be on the same page, because muscle is not just muscle. It's not just muscle here, and there's a little bit of connective tissue. There's a tendon here and a little bit of an interface. Really, what is important and what is shown here, and I really would have loved to have a pointer. Here, oh, there, no, it's big, but cool. Why? I've never seen such a big pointer. This is the hamstring. Good. Muscles. Anyway, and here, look at the mouse. This is the intramuscular tendon, and I call it aponeurosis throughout my talk mostly. So you see, it's not just a really small area somewhere up here. It really goes into the muscle, and yeah, that was the. Oh God, sorry. And if it's really schematically visualized, the biggest part of the muscle is covered by connective tissue, and every single muscle fiber is surrounded by connective tissue. So keep that in mind. If you talk about muscle, it is not just muscle tissue. It is to a high degree also the connective tissue. And along, now I really use my arm because I want to show you the real, where you have to focus. Along the connective tissue muscle interface, we have the myotendinous junction where the muscle hits the tendon, all right? So the green here is the muscle, then there's the interface, and this is the tendon here. But this is not just a small part of the muscle. It is just really a big part of the muscle is connective tissue. When I talk about muscle strain injuries, I talk about those strain injuries where we see something, where we can see a defect, and I come back to that. Sometimes you don't need to have a scanner. You don't need all those nice imaging modalities. You can see what's wrong and which leg is injured. But we do use ultrasound, and I know there will be an excellent session later on imaging. I just use the ultrasound in order to show you the questions that we have and the answers that we try to get to. So basically, here, oh no, we have it. It's perfect, wonderful. Now I just have to hit it. Obviously here, the defect is here. And you see the connective to the aponeurosis is right here. So it happens, it always involves some kind of connective tissue. And it's hard to visualize on an ultrasound. But when we dig deeper into it, I think it's pretty clear. Now let me see. This is a healthy hamstring. Just doing a static contraction. Now he contracts. You see the fascicles do shorten. Relaxes again. There's movement. The fascicles shorten. This is physiology. This is how it should look like. I move over to the injured part. First of all, there is the hematoma here, or we call it also exudate, so it's within the muscle, probably also around the muscle. And now this, just a couple of days old, tries to contract, does also something, and relaxes again, tries to contract again and relaxes again. Now, what is my point here? My point here is, yeah, it's in early 20s, but there is I hope you could see that there is an area where we can see there's a discontinuity of the muscle fascicles inserting into the tendon. This is the aponeurosis. There is a defect here. So basically the question comes, how do those fascicles attach again? And how is the connective tissue affected? And we address this question. We do a lot in the hamstrings. We do also a lot in the calf, because we see a lot of calf injuries, especially, I don't know, since the rising of the paddle tennis, I don't know if that's big in Switzerland. In Denmark, it's really big. And the rise of injuries, especially calf strains, is quite dramatic, I would say. So we have a healthy calf, and we have the injured calf. Basically, where is it? There. Basically, this is the medial gastrocnemius. Basically, it should sit somewhere, no, here. So it's really torn up. It's not just muscle, because you see this here is the deep aponeurosis. So how is this interface affected? So we did a study by using 10 subjects with a previous confirmed strain injury. This was years ago, and we called them in. We did ultrasound static in different angle positions. Don't want to go into that so much, but we did also dynamic ultrasound recordings while they did a heel rise, up and then down, and we held the ultrasound probe. Let me see. This is the healthy calf. You can see again the fascicles contracting. I'll see if I can use the point again. So it goes up on the calf and relaxes again. I say a lot of he, because we have 95% are men. We hardly have any females. So going up again and contracting, and then going down on the toe again. Down to the level again. So the fascicles contract. This is normal. This is how it should look like. This is what we measured. Now, this is the injured side, years after the injury. Medial gastrocnemius, here he goes up on the toe and then back again. Let's see. Moves up again and down. I'll have one more video. And it looks blurry, right? And then now you could say, now can't you even get a nice ultrasound image? But we can't, because this is how it looks like. This is a tissue, first of all, not contracting in the proper way. I'll tell you that. But the whole area here, again, it's not because we hold the probe in a wrong way. It is because this tissue has been torn away from the connective tissue, from the aponeurosis, and is also years after looking pathologic, and also behaving pathologic. See, this is how it looks, and this is not physiology. A muscle fascicle, muscle fibers, can never curl in. So I'll just use my arm again. Muscle fascicles do contract, do shorten, relax again. Now, in this case, in the injured, years after, they roll in, and then they move out again. And this is not this can't happen. This is not a contracting muscle fiber, but this is a muscle fiber fascicles that just hang along and move along, because it's still attached apparently and obviously to the aponeurosis down here, which is really enlarged. I come back to that also. But this is just visualizing that the area of injury is not healed in the proper way. They all came back to sports, but years after, there's a lot of pain, there are a lot of cramps, especially in the calf, there are a lot of cramps, and also it feels weak, or it feels different. And this is the feedback that we get, it feels just different. And now what can you use that for? Anyway, we tried to measure the, as researcher, you always need to get some data, so we tried to get the data out, and how do you want to quantify this rolling in? We tried to do that the best way, so assuming assuming a straight line, which is definitely an underestimation, but what we can see is the pennation angle is different in the injured area compared to the healthy area. The fascicles are shorter in the distal medial gastrocnemius. This is the fascicle length that we looked at, is shorter there. I don't want to spend too much time on it because of my time constraint. What I want to focus on now is on the aponeurosis, because we measured also the aponeurosis at 3 different points. We have the uninjured side here, and we have the distal part, but we also measure the part up in the mid-belly where it looks a little bit more normal. What this figure shows, there's some arrows up and arrows down, and what does this mean? An aponeurosis is extremely complex. The mechanical behavior of the aponeurosis is complex. In a normal and an uninjured, in the distal part, there should be a small increase in width, and in the mid-belly, there should be a small decrease in width. This has been shown before, and we see that in our samples. But then on our injured side, which is on the left side here, during contraction, there's always an increase in width. So this means, translated, it's not only that the aponeurosis is thickened, but it also behaves very different compared to the healthy side. So the fascicles attach to something, to the connective tissue that behaves different. So how do we call this? Is that some kind of a scar tissue? And this is what we dig a little bit into it. Because in a previous study, we saw this blurry, or you saw that hopefully also, the blurry picture of the medial gastrocnemius. We went in a previous study, and we do that at the moment again, and we do it in acute injured, so let's see how this goes. And so far it goes quite well, but we did, in chronic strain injuries, we went with the ultrasound guided, we went in and took biopsies out. Why did we do this? Because only when we take a tissue sample out, we know what's going on in the tissue. So this is what we found. Years after the strain injury, complaints are pain, cramps, and recurrent injuries. This is a muscle fiber, right? Now, let me just see. I'll just go. This is a normal. This is how it should look like. We are all the way in a muscle fiber. These are the sarcomeres here. You see the set lines, nice arranged. Now I go back because this is crucial. And I think it's quite clear by eye. It is very disorganized. And why are those white spots here? Here are areas where we don't have any sarcomeres. So basically, this muscle fiber, I would say, it looks very much non-functional. We have those white spots. I just mentioned it. What is that? A big white spot here. This is fat. This is fat within a muscle fiber. And the muscle fiber has a nice basement membrane, so it's intact in a way. But within the muscle fiber, it looks really pathologic. Now we zoom a little bit out. This is again a biopsy where we take from the muscle, from the pathologic muscle. We see the muscle fibers here. It should look like this, really nicely orientated. These are the muscle fibers here, and the dark dots, these are the nuclei. I'll go back again. One thing is, and take this along, this is a scar tissue which is really active, and we can see that by the number of cell nuclei. So there's a lot of going on, even years after the injury. And also then really squeezed in is really, the fat really comes in and makes space there. So the fat really comes in. So this is a pathologic muscle here. I have some more images, and we are not in a fat tissue, so we know where we are. We are in the middle of we are in the muscle because we take ultrasound guided. But this is basically everything should be muscle and then some connective tissue. But this is what we have. We have vast amount of lipid accumulation in the muscle, also here and here. And zooming really out again on an MRI, this is a year after the injury now. This is the healthy side, gastrocnemius, here's the soleus. One thing is, you can see that right away, I hope here, there is loss of muscle mass. And yes, he or she has been rehabilitated, is also back to sports. Now all this white stuff here is the fat. And the thick black line here is the enlarged aponeurosis. Good. And now I said the connective tissue, I had to focus on the connective tissue. I go again all the way into the ultrastructure of the muscle, again on electron micrographs. What we have here, we have the muscle, we have the last sarcomeres. This is a healthy site. So we see this, I don't know if you have seen it many times, but if you look at the muscle tendon junction in the muscle, where else? You have the finger-like processes, and it's much more complex, but it looks like finger-like processes really nicely. And then here on that side, it's the extracellular matrix. And what you can hopefully see here, it's those dots, really dense, organized. This is the connective tissue. These are the collagen fibrils. This is how it should look like, and this is an injured site. So we have still the muscle here. Here we have the basal membrane here, and we have what are those dark dots. These are mitochondria. They accumulate just below the basal membrane in a pathologic muscle, not just a strain injury that has been injured in pathological muscle. And then we have the extracellular matrix part here, and what you hopefully can see, it's disorganized and it's not densely packed. So really here is probably the area, and I have another picture here where we zoom a little bit more into the extracellular matrix part. There are some collagen fibrils, but they are not that densely packed. There are more cells and really disorganized. And I have one more here, so there are some collagen fibrils here, a lot of mitochondria again here, and here there is just not this densely packed connective tissue, which is a problem because we need the muscle to have an anchor, okay? Need to have this interface, to have force transmission, but also to have a functional and a strong interface to also prevent then re-injuries. Now, why does this happen? Why does it not form? Again, why is it not, let's say, the developmental process is recapitulated? Why is there scar formation? Probably because we have an area where there's an unloading. You remember the calf where they go up and the fascicles roll inward. This is not a contracting muscle fascicle, so this is some part is unloaded or to some degree unloaded. But also what I spent now a couple of minutes on, we have prolonged inflammation. We took some samples from exactly those hematoma or exudate just days after the injury, but also many days after, up to 60 days after. We took also blood samples to compare. Now we wanted to look what is in that area, what is secreted from this injured muscle and the injured connective tissue. And what we see, and I don't go into all those targets here that we looked at, but basically it's a highly pro-inflammatory profile. Now, is that surprising? No, because there is an injury, then you have inflammation. But my point is, when we look at different subjects who came in at different time days after the injury. And this is random, and this is when you work with people, it's just you have a plan. Maybe we take some samples in the first week, and then they come 2 months after. But afterwards, it was actually quite good because what we could see is the subjects coming in just a couple of days after the injury have exactly the same profile, pro-inflammatory profile, than those that come 2 months after where we take the samples. I know it's not the same patient, so it's hard to say this is longitudinal, but it is the same profile. And this says that, or tells us, suggests us, let's say like this, that there is a highly pro-inflammatory profile for a very long time, and this contributes to scar tissue formation. Now also, and I spare you really the details here, but we also looked at the cells that are active in the, when we take something out and we want to take really all information that we can get out. So we looked at the cells, look at RNA sequencing, but what we could see already a couple of days after the injury, that there are some, down here in the red cycle, there are some molecules upregulated that are involved in the adipogenic pathway, meaning that already there it could start the fatty infiltration into the muscle. Now, which tells us obviously what can we do, how can we prevent this? Now I zoom a little bit out from all the molecular stuff. Loading, obviously, is a good thing. We just heard too much loading is too much. But after an injury, what we found out, and several before us and several after us, rest is just not a good idea. So you have to load the tissue. So you have a faster return to play. Does this change the tissue? Not at all. There was not any parameter on the tissue level that was different from the early loading group to the delayed loading group. There was exactly the same degree of muscle volume loss, which does not recover, but absolutely no effect of the early loading, which is kind of a bummer. But then you can think maybe this is just because it cannot. It is just disrupted. It cannot load. It cannot be loaded that area. So then we need to think how can we then load it. But we thought also what do we do then? We give them a really big anabolic stimulus. And we just did that, and it's not published, so don't put it on whatever. It's just about to come out. We gave the participants early loading plus protein versus placebo. Then we did now calf again and hamstrings. I just show you the calf data. We looked at the volume and if there is a protective effect of the protein supplementation. We see, here's the injured, and I come to the end, I know my time is up. We have the injured versus the healthy. We have the medial gastrocnemius. All the injuries are placed in the medial gastrocnemius. Here's the lateral gastrocnemius. Here's the cellulars, and we have the whole volume. We see again the significant loss of muscle volume in the medial gastrocnemius. We have a significant increase in muscle mass in the lateral head of the gastrocnemius. So there's some kind of compensation, but absolutely no effect of the protein, which is kind of a bummer. But then also when you think there's a part which is probably just not loaded, you can't just actively load it, it makes kind of sense. Also between the placebo and the protein group, absolutely no difference in the days returning to sport. I come to my last slide. We have a repair of tissue damage, obviously, and most athletes come back, if not all athletes come back after strain injury, but we have a high risk of re-injury. And we do know now that there is a part of the muscle attaching the tendon, the aponeurosis, which is not repaired properly. There is a defect. We know muscle contraction is a necessity, but we also see that there's a part which is just not contracting, it rolls in. And we speculate that this is permanently disrupted. There are muscle fibers that are not contractile, and exactly in that area we see a massive infiltration of fatty tissue, fatty infiltration of the muscle tissue. This is something that we need to work on, probably in the very early phase, and it's always good that there's more work to be done for a researcher. So with that, I hope at one point I might come back and tell you a bit more optimistic things. Not that it's just permanently damaged. I mean, there is a lot you can do, and you can strengthen the area around it. But my time is up, and this is not the topic of my talk. I just want to stop by thanking again Mario and the whole team for having me here, and my team and my sponsors. No, I don't have any sponsors. My funders. Thank you very much.
Thank you very much, Monika, for your presentation. Are there some questions here in the room? Yes, here on the right side one, and then here. Please, the hand. Can you put on the hand? Fine.
So, hello. I was wondering, since connective tissue is so prevalent throughout the body, if this mechanism also happens in other tissues, ligaments, tendons, bones, etc.
Yeah, absolutely. No, it's a perfect point. Connective tissue or tendon, ligaments, really poor repair capacity. It has a lot to do with the low turnover versus the high turnover, by the way, in the muscle, high turnover. But really a perfect point. Connective tissue, ligaments, tendons, and so fascia, so difficult to repair because they just have a really low turnover, low vascularity. So yeah, excellent point. I can only repeat what you said. Yeah. Mm.
So what this basically means is that in all tissues there will be, as we understand it now, damage forever.
Just think about when you cut yourself and it's a sufficient big cut, you will get a scar. This is how we heal when we are adults. There's a small window, especially in the embryo, obviously, but you don't cut. Thank goodness. An embryo heals. This has also something to do with the inflammation. But there will be some kind of scar, and this is also another. Now this is just a small scar. Think about if you take just a biopsy in the tendon, in the patella tendon, you will change the whole tendon, not just this small part. There will be some changes in the whole tendon, and you will see this change years after. So yeah, there is to some degree probably a small area which is different from before. Now the big question is, of course, how big is the damage and how big then is the healing. But I can't say it for sure that every single. But there's a really high poor repair capacity, so there is a high risk of permanent changes. Let's call it like this. Damage sounds.
Yeah. Thank you very much.
Of course. Thank you for your question.
There is another question here. First.
Just
comes.
Oh.
My name's Nicole. So that's a really fascinating talk. So isn't that good news for us as physios? So one of my questions is, could you clinically, are there clinical clues to the re-injury from the pathology? Or even if you're doing really well clinically, as the physio in the team, I've got it now that you've had an injury, you get extra attention. We've got to keep loading this tissue. We've got to make sure we try and protect you because you do have a higher risk. We know that, right? So we do have a higher risk. But this is, to me, seems really just logical now and something that maybe makes us think differently about re-injuries. What is a re-injury really? If you're damaging the place where you're not healthy, and can we, through loading techniques and our approach, do that, influence that?
No, it's an excellent point. I need to. So the take-home message is, you have to keep loading this. One thing is the early loading, but then you don't stop when you know this player is, it feels fine again and I'm good. You keep loading this area because you need to strengthen, and you see there is a compensatory effect on other muscles, but also on the connective tissue. Even though there is such a low turnover and low repair capacity, low adaptation capacity in connective tissue, when you do strengthening, when you do loading on the connective tissue, there is adaptation. This is so crucial, especially also in the muscle strain injuries, because you keep protecting the area around, and probably also the area where it's injured, it's to some degree, let's say it like this. So excellent point. Thank you for pointing this out. Take this with you.
We have a lot of questions also on Slido, and I will just try to sum up some of them about anti-inflammatory drugs.
Yep.
Is it good, not good?
Yeah, I always get in. It's so tricky. So evidence out there is muscles do heal and also tendons do heal poorer when you eat anti-inflammatory. Now, because there's an injury, you need the inflammatory phase. You need that because there need to be the cleanup. This is the normal biological process. But the question now, and that's the tricky thing, and that's also what we are targeting in the coming month. So you have the prolonged inflammation. Would it then be beneficial to dampen the inflammation later? And this is probably beneficial, but we don't know. But inflammation, it's a biological process. It's a necessity. Now I have it for the tissue also to heal. You need that. The macrophages that come in, they secrete a lot of factors that need to be there. So do not. So right now, I would say no recommendations for anti-inflammatory medications after muscle and connective tissue injuries.
Good. Thank you very much.
Thank you.
Thank you very much, Monika. So, wir haben jetzt eine Pause. Wir würden dann hier um 11:15 wieder weitermachen. Ich bitte um Pünktlichkeit. Die Pause findet unten statt, beim Eingang. On fait maintenant une petite pause et on va se retrouver ici ponctuel à 11h moins quart. Je vous prie d'être ponctuel.
Voilà, c'était bien, non? Comme ça.
Très bien.
Je ne veux pas découvrir.